Thank you, Dr. Samir. We have an eminent panelist for this discussion. We have UNICEF consultant, Dr. Shravan Chenji. I request him to come onto the dais. And we have the three eminent pediatricians, Dr. Sanjay Gorpade from Satara, and Dr. Jayan Joshi from Pune, and Dr. Nischal Bhatt from Gujarat. I think all of them, you know, they are very eminent ID chapter pediatricians who have been giving a lot of lectures around the different places. So our topic is given 30 minutes, 10 minutes is cut down. So I request the panelists to be precise to complete the discussion. Yesterday we was seeing so many people talking about the vaccines and how the vaccines have fared since last 50 years of expanded immunization program which has been implemented all over the world. And it has shown great fruitful results. If you compare the recent Lancet paper which has shown that 50 years of expanded immunization coverage has led to the total about 150 million deaths have been averted, and at the same time 9 billion years have been added, and 10.2 billion healthy lifestyle has been there. This has been published in the Lancet recently. It is May 2nd it has been published. Since last 50 years, what are the gains regarding the vaccination? And having the vaccination is not enough. Having the vaccines is not enough to protect the individuals from the diseases. Vaccination is very important, as told by our Ignesh last day. So first question to our UNICEF specialist, Dr. Shravan. I just want to know what is the coverage as per the NFHS data. So our idea is to improving the coverage of the vaccination. The coverage of the vaccination is very essential to bring down the transmission and bring down the incidence of the disease. So what is the coverage, latest coverage of the vaccines as far as India is concerned?
So if you see the coverage data as per the National Family Health Survey, so I just would like your attention to the slide here. So if you see the graph, when we compare what is the national level data and you see the disaggregated data at the district level, you can see, say, example for Gujarat, it's all green, it's all looking quite good. But if you go a little bit more deeper into the districts, the scenario is a little bit different. Even though the overall coverage is 76%, you can still see there are districts which are colored in red where the coverage is less than 50%. And these are the reason why we are not able to achieve the overall coverage of more than 90%. So even there are districts like Banaskanta where the coverage is still around 40 to 50% even in the recent times. And we have been hearing of many measles outbreaks and other VPD outbreaks coming up in the districts. So the point is, even though it looks like it is 76%, actually there are pockets in which there are VPD outbreaks still happening, and these need to be focused upon. Next slide, please. But what are the reasons? One of the two common areas why there is deficits in full immunization coverages, if you can observe the left-hand portion of the slide, the education of the mother plays a very important role in whether the child is fully immunized or not. And families belonging to the lowest wealth quintile are again the worst affected with lesser immunization coverage rates. Particularly the populations living in the urban slums, the migrants, the construction workers, the tribal areas and the coastal areas, which we call them as the vulnerable groups. And when we see the urban-rural variation, it looks almost the same, but I would like to highlight that in the urban areas, the urban poor are the worst affected in immunization. So please don't take this figure of urban as granted. We need to understand how urban poor are affected further.
Yeah. As far as vaccination is concerned, there is a lot of difference in different areas as far as India is concerned. We know that there are various reasons why this coverage is less in some areas and why the coverage is very good. There are enough reasons have been documented in different papers. We will go through the reasons in the due course. And this is the latest data of NFHS. What it's showing is, so overall coverage of BCG is 95% and 3 doses of polio 80% and pentavalent is 87% and 1 dose of measles coverage is about 88%. That looks very good, when it comes to the national average. But individual pockets, as Dr. Shravan told that, there are some pockets where it is only 50% or 60% where you have to concentrate and tackle the reasons. What are the reasons for the less coverage? So, as far as the COVID is concerned, during the COVID time, there is definite decrease in the coverage of the vaccines in the national immunization program. And this is the catch-up vaccination with the measles, with MR campaign, we have almost achieved about 90% of the coverage. And for common pediatrician, most of the times practicing pediatrician do not bother about the national statistics, what is it. So as far as WHO concerned, there are certain definitions are there. One is what is a fully immunized child, what is a zero dose, and what is an unvaccinated child. I request Shravan to just identify what are the zero dose children and why are we lacking in spite of having a very good immunization program for since last 50 years. Still we have the largest number of zero dose children as far as India is concerned. It may be because of our population is more, the number is more, but still we have a lot of number of zero dose children.
So zero dose children by definition are the children who have not received any basic vaccinations. But to identify the child operationally, we call them the children who have not received the first dose of pentavalent vaccine. So they are typically what we call as the zero dose children. And currently in India, there is almost 1 million of zero dose children currently even till date. As per latest data, 2022 was the estimate, there are 1.1 million. Even going by gradual reduction, we still have probably 1 million children. And as per NFHSY, 6.4% of the total age group are still under zero dose. And the problem is these zero dose children are focused on all kinds of pockets just we have identified. Urban slums, urban poor, vulnerable groups, construction sites, migrant workers. These are all the pockets in which typically the zero dose children are present, and because of which the vaccination is not being done properly and VPD outbreaks are happening.
Yeah, we know why you have already enumerated a lot of the reasons where the zero dose is existing. That is urban slums, vaccine hesitancy, migratory workers, and hard to reach populations. Some of the areas, maybe the ASHA workers are not able to reach, and tribal populations. So various barriers are there. And this is what happened during the COVID time. There is depression of DPT coverage is there. There is slight increase in the coverage post-COVID definitely, but as far as measles is concerned, we could not still reach the pre-COVID levels of vaccination coverage. This is what measles. So pre-COVID it was 90%, post-COVID it came down to 81%, and now it is only 84%. Still the measles is still lagging behind as far as the coverage is concerned. So anybody can take this question apart from Shravan. What is the immunization agenda of 2030 by WHO? Sanjay can take.
Yeah, up till now, Dr. Shravan has highlighted, yes, there are outbreaks of the measles, recently last 1 year mumps, and of course pertussis is intermittently going on. And whatever data that is being shown, yes, that is not to the tune of the 100% in spite of lot of efforts done by the government of India, UNICEF, etc. So that's why this is come into the picture that is called as IA. IA means Immunization Agenda 2030. So whenever we are discussing the immunization agenda in the 2030, that means, go for the next slide. That means the immunization for every child, whatever the else is, that is anywhere, everyone, and whatever the condition the baby is. That is called as the word where everyone, everywhere, and at every age, the child should get immunization. That is number one. And motto of this is to decrease the, of course, mortality in the kids and mortality in terms of the neonatal or infant mortality. That is second part. Second part, irrespective of anything, every kid should have, is having right to have a fully immunized with the whatever available vaccines are available, and leave no benefit, no one behind, increasing the equilibrium or access, etc. Third, and this is for the good health, ultimately our final aim is health for all, and this will be the strategy in the IA, that is called as Immunization Agenda 2030. And accordingly, the yes, government is promoting all the things. Of course, UNICEF is supporting, and on behalf of the private sector, yes, IIP should actively take part in this mission, whatever is been going on.
Yeah. So this is what immunization agenda is: a world where everyone, everywhere, at every age, fully benefits from the vaccination for good health and well-being should be taken. So this is the idea. By 2030, WHO want to implement immunization agenda, and our UNICEF expert is there. Just be brief. What are the strategies and core principles of immunization agenda?
Next, please. So I will quickly summarize it into 4 core principles for action. So first of all, most important is it should be people-centered. Whatever strategies or whatever actions we are taking, we need to keep in mind the demands and the perceptions, traditions, myths and beliefs of the population and then develop the strategy accordingly. Secondly, it should be country-owned. Whatever strategy we are investing or recommending, it has to be owned by the government. The government should invest in it and take the ownership and make people accountable for it. It should be partner based, and this is exactly today why we are meeting in this forum. We need to convene partnerships both in the public sector and private sector with professional bodies like IAP, AOPG, NNF and others so that it will be a multi-stakeholder effort altogether. And finally, it should be data guided. Unless we have the data, we cannot take action. And we need to strengthen our platforms where we can use data for decision making. And the best example of this would be the impact initiative which was done by AOPG, medical colleges and UNICEF together, which would be further discussed.
Yeah. Data is very important. We are struggling to include the mumps vaccination in the national immunization program. Every time the Minister of Health says that we don't have any data of the mortality of the mumps or morbidity of them. So data generation is very important. That is what very important as far as pediatricians are concerned. From the private sector and the government sector also, both the pediatricians has to report the number of cases which they are seeing. But that is not happening nowadays. Maybe that is the reason some of the vaccines are not included and the coverage is not there. So the principles of the immunization agenda as far as the coverage and equity is concerned, it is people-centered and country-owned. It should be different for different countries depending on the situation, and partnership-based as the UNICEF and the private practitioners partnership, and it should be data-guided. So if Nischal wants to add anything, because they did one very good program as far as Gujarat is concerned, that impact program, just be brief.
I think it will come over a period of time, so we will discuss it afterwards.
So now we will see reasons for the lower coverage. Jain Joshi, in your practice, what is the reasons for the lower coverage of the vaccinations, whether in the private practice or in the national immunization program?
See, there are various reasons. Of course, there are social reasons, there are some limitations. Of course, poverty, priority, everything is there. In COVID times, because of a lockdown, there was a significant drop in the vaccination rate, which we all witnessed. In particularly some communities, there are larger families, there is no access. There is a very interesting study which has come in terms of tuberculosis also, that in certain pockets of Mumbai, there was a marked rise in adolescents who had tuberculosis. They were not accessed at all because those localities were not accessible. So there are various reasons, as you can see in here. Families migrate, if the delivery is held in difficult areas, there are language barriers, there can be several social problems and sometimes some misunderstandings as well, because there are some vaccines which are attached to some kind of a taboo in society. So all these things are, there are social factors, there are logistic factors, there are administrative factors, but all said and done, it overall impacts the vaccination schedule.
One flash question that is not in the slides. Discrepancy between the national immunization program schedule and the ACVIP schedule, how does it affect the coverage of the vaccination is concerned?
Thank you, sir. I think you have brought out a very relevant question, particularly for a private practitioner like me, and I think many of us in the audience will agree with me. Nowadays, the trend of taking vaccination in the government setup has started increasing. And we come across these children babies who come to us at somewhere around 4.5 months, 5 months. They have taken the schedule according to government this thing. Now, all the forums on vaccinology up till now have been recommended that the fractional IPV dose is not adequate. So ideally, every child should receive at least 1 full dose of injectable polio. The government has a program which has MR, and the ACVIP recommends MMR vaccine. So there are some difficulties where how you to attune to these babies who are partially vaccinated at the government center. And sometimes in our city, we have noticed that the government, the corporation officials are quite casual. They tell the parents, yeah, everything is done now. Now you directly come for 1.5 years vaccination. So a very important set of vaccines which a baby would otherwise receive in a private clinic, like an MMR vaccine or maybe even a pneumococcal. Now they say 9 months pneumococcal booster vaccine is enough, but I think from the ACVIP recommendation, we recommend another pneumococcal booster vaccine at 15 months of age. So there is definite discrepancy between the government schedule and the private schedule, and I think we must be insisting on all the patients who come to us who have been partially vaccinated in the government setup, that at least these are few vaccines which must take over and above. So that is what is important. Thank you.
Can Mr. Bhatt add anything? How to bridge the gap between national immunization program and private practice?
This is really a concerning for all private practicing pediatricians, because gradually the vaccination is going towards government. But that is good. As it has been discussed, public-private partnership will definitely help us a lot. We as a private practicing pediatrician, we should just gap whatever is there, we need to complete that. So that whenever a child who is taking vaccines from the government setup in the initial time, usually they come to us for any illness. Every illness we must find out what vaccines are given and what vaccines to be given. So every time if we prime parents about the lacuna which is there at present for that particular child's protection, they will definitely motivated to take the vaccines which are not given at the government setup at our place. So every visit, we must, even sick visit, we must find out what vaccination has been given, and we must prime them so that they come for other vaccines. Going ahead, if we find a parent who has come to us for routine checkup are not affording the primary vaccination at private setup, advise them to go to government setup to take the vaccines at 1.5, 2.5 and 3.5. They will definitely come back to us for the remaining vaccines, because they realize there is no kind of financial things in this doctor's mind. So this all public-private partnership. One more thing we tried, it may come in near future, is with the help of impact, the government and public-private partnership, we can even start giving those vaccines which are available at government setup at our place. Government is ready to give us these vaccines without cost. We can just charge a vaccinator or a kind of professional charges from them, so that we can keep that log, so that the government vaccines are given free of cost at our place, and the remaining vaccines can be given at our place with a cost which is already there. So these are the few things which we can add and definitely reduce the gap between NIP and the SAVIP schedule.
Dr. Sanjay?
I fully agree with whatever the things actually told by Dr. Nishal. Definitely, whenever we are promoting the vaccination, especially in the private sector, yes, whatever the vaccines in the government sector, definitely will promote. And along with that, if there is financial problem, just there should be options. One, they should take with the government, or same action if we are making available, that will be a good option. But remaining action, we should go ahead with the whatever private actions will be available. And many times this lag happens because, see, where we are using the rotavirus vaccines since last 10 years. Now the government had taken that rotavirus in the government program, but maybe the financial problems or operating system, etc., at the public level. Second thing, the same thing happens with the pneumococcal vaccine. So whatever vaccines, what we are talking now about the MMR, we are highlighting about MMR and government doing MR, because this, what is the mumps is rising. Same thing actually, yes, we should be behind the vaccination of the all kids, whatever the possible mean or way will be. But in the due course of time, we must push the government bodies also to have, yes, these are the vaccination, essential vaccine, and we should add this vaccine in their NIP schedule also.
Yeah. Majority of them may not afford the vaccines given in the private sector. As Nishal told, that ask them to go to the NIP vaccines. Once they complete their schedule, they can come to the pediatrician and can give the catch-up vaccination which are not included in the national immunization program. But every visit, I think it is our responsibility to see whether which vaccines have been covered, which are not covered. If those who are not covered, give a fresh immunization card to them and tick them that these are also essential. One question to Shravan. So most of the time there is some shortage of the vaccines which is affecting the coverage of the national immunization program. Not only the pockets where we are not able to reach, but even in the urban areas, in the prime areas also, there is some shortage of the vaccine. How UNICEF is trying to deal with this problem with the government, with the shortage of the vaccinations?
So the answer to this would be shortage used to be an issue, but if you can see with the advent of systems like EVIN, Electronic Vaccine Intelligence Network, and now it is being upgraded to UVIN, where UNDP is also working with the ministry, they have developed an excellent system where you are going to forecast the vaccine requirement 2 months beforehand, and the system is so robust right now, almost it's a rarity in the public health sector to see a shortage of vaccine, because shortage right now refers that the buffer stock is not present in the facility. But every single session site which we call Mamta Divas or at a PHC or a UPHC, every session site already the stock is pre-placed based on the number of mothers or children who are coming to the site. So my answer would be shortage may be there, but that is related to the buffer stock. But right now shortage at the session site when the mother child is almost non-existent. And I can say this is one of the most powerful strengths of immunization program in India, which even other countries are trying to replicate right now.
In fact, post-COVID, our data system has been very good. In fact, that has learned us how to keep the database. And this cold chain maintenance data is very good as far as India is concerned right now. So shortage of the vaccines will not be there in future, I think.
So at this juncture, can I just ask you a question? You mentioned about that zero dose category to be brought to less than 50%. Don't you think 10 years is a long time to achieve that? Because the government is targeting to do it by 2030. See, you have already lost a sizable population who is not vaccinated from 2020 onwards. So keeping a goal of a 10 years period doesn't appear to be too long.
So the 50% reduction is in the baseline values 2021, and based on the current, suppose there are 10 lakhs children which is present at the baseline data, by 2030 we want to reduce it by 5 lakhs. That was actually what 50% reduction means, and it is actually not easy. Why, I will tell you. Right now urbanization is at 45% in Gujarat. By 2030 it is expected to reach 60%. The more urbanization is happening, the more urban poor are coming in. And even right now, we are working with the corporations, with the commissioners to understand how to track the migrants. There are families who come and stay for 3 months. They have rental agreements for 3 months in corporations, working in Surat, working in Baroda, in areas like Bharuch, in all the pharmaceutical companies. And this is the biggest challenge why we are unable to bring it down at a faster pace, because we need to adapt to increasing urbanization and increasing urban poor presence. And this is where, again, I'm reiterating, we need your support. Because I think in further slides, we will see mothers are most convinced by private practitioners or the pediatricians or their family doctor. So if you are able to connect to the urban poor, convince them to go for the free vaccines, at least to the government setup, sir, I agree, we will be able to achieve this at a faster pace.
Yeah. Dr. Jain Joshi, what is the importance of mother's education as far as the coverage is concerned? We have a very good data which is there in the...
Sir, it is very important. I mean, like, it goes without saying that, you know, if a mother is illiterate, she will be more difficult to get convinced. A educated mother is definitely an asset because she is aware about all these vaccine preventable diseases. So as this slide shows that if the mother is not educated, the incidence of those children having a zero dose status is likely to be more than 20%, which is worrisome. So it goes without saying that educational level of the mother is very important.
So maternal empowerment and education are very important factors as far as improving the coverage is concerned. Okay, thank you. What are the solutions? Nischal Bhatt can take these questions. And we are having a decreased coverage. We are having not able to achieve the targets. What are the solutions?
As it has been said that what is the reason for any movie to get absolutely successful? It is entertainment, entertainment, entertainment. Same way for immunization, it is education, education and education. If we create awareness through education and training and then motivate them to act, definitely this will go away. The most important thing is now many schools in Ahmedabad Corporation and other corporations have a form every year the child has to fill. That child is immunized for the age, Even influenza vaccine has become compulsory in those schools. We have got one school in Ahmedabad who gets B12, D3 and hemoglobin level of every child before their next year's entry. So they do diagnose them very powerfully. So this kind of school entry laws, which is there in developed nations very well, we have seen adolescent coming to us for completion of the immunization and the chart completion because they have to go to study abroad. If that can be done in India in schools, but it is a double-edged sword again. There are school dropouts because of no vaccine is to be taken by the child and mother is not educated. So education of the mother, a life cycle approach. A teenage girl is educated, there is the time of the marriage is delayed, the first child born is delayed, there is a gap between two children. If the mother is educated, definitely this can be curbed.
One question to Shravan.
Second,
Can we implement this
just 1
school
minute.
entry card?
For cost, again, a public-private partnership will definitely help us in a long way. Connecting with all the program, WCD and the health department as well as maternal child program will definitely help us in a long run. And the COVID is an amazing experience because there is a immunization quality improvement which has happened across the nation. The political will, the scientific community coming up together, the industrial giving capital, and we as a pediatrician increasing awareness about the importance and requirement of the immunization. These four things will definitely improve the vaccine coverage in our country.
I want to know whether school entry certificate will be effective. Will UNICEF propose that school entry certificate is essential?
So the certificate for immunization as part of school health program is being thought of, but there are pros and cons to it. We can impose the certificate as mandatory, but as it happens with the road safety laws and licensing and other mandatory certificates, people will always find ways to go about it. But I agree with Dr. Nishal, the solution is indeed education and motivation, but I want to just add the term behavioral change. Unless we motivate the parents to agree that they need to immunize their child, only then this would be successful. If you are forcing a family that you have to get this without this certificate, we will not allow you. Definitely they will go to a practitioner, get their seal, get their signature, and then admit the child. So instead of making it mandatory, let us focus more on behavioral change.
The system has to change. I think government should take the responsibility of vaccinating 100% children. Then they can ask for the school entry certificate.
Yeah, that is a means positive reinforcement. We can say that terminology that has been explained as vaccine hesitancy. Hesitancy means yes, vaccine is available in the market, everything is available in the market, still patients are not taking it.
Yeah.
And that is the main issue, along with the education is one part. That is not in the literate families. But yes, where the uneducated families are there, that can happen. But even educated families, there are maybe some fallacies like pathies, especially homopathies. They will not take at all in vaccination. So we must, yes, promote that vaccination is number one. So that is called as a positive reinforcement. Another important part is the share. That means this is a share means share the tailored reasons why the vaccination is recommended. Number one. Second, highlight about the positive experience. Number two. Third, address patients' questions. Give the time for the counseling before the vaccination. Remind the patient. Yes, certain reminders must be messages sent that this is your next date for the vaccine, and explains the potential cost, but should not be in such exaggerated manner. So like that, there should be a balance. Yes, government vaccines are available. You take it. Those are not available after 6 months. Yes, we can go for the typhoid, whatever the vaccines calendar is big. So like that we should be. But every vaccine, yes, even the government is available that we must take from private. We should not insist like that. So there should be options should be given the patients. So our main goal will be the maximum vaccination. What is the already told by Shravan, what is the percent of vaccination? Still 87% or between 80 to 90%. That's why there is no 100% vaccination. So main goal will be the 100% vaccination. That should be our goal. That's why we are saying that IA, that immunization totally by 2030, and that will decrease the zero dose polio. Definitely what Jayant was saying for.
So I think we are running short of time. I will ask Dr. Jayant Joshi. So how to reduce the coverage, I mean, increase the coverage of the vaccines, how to reduce the dropouts. There are some...
I think we discussed about what can be done at the society level, community level. At the private practitioners level, what you could possibly do is maybe give a different time for vaccination. particularly for working parents. Now they are having holidays on Saturday and Sunday, so maybe give them an appointment for Friday evening, and they would definitely prefer not their children, normal children, to be brought in a OPD where there are a lot of sick children also. So there is quite understandable. So maybe a slot can be prepared for them. So you could avoid that. You can give now online appointments are possible. So you could give them. You can equally send the reminders to them through those apps, and transportation issues can be dealt with. Sometimes you must clarify to them that most of the vaccines would not have any significant side effects, particularly the ones, because there is always a fear a small
Yeah.
baby will get side effects. So
these
that
are-
we have to clarify.
These are some of the things which we are supposed to do at the clinic: reduce the waiting time, give the appointments, reduce the long queues. Most of them don't want any long queues now. So, so this is what the final thing is to complete the immunization. So accessibility, access is very important, availability. This can be achieved by the camps and immunization drive. And as far as awareness is concerned, media campaigns, community outreach by health workers, behavioral change, communication, interventions we have to do. And promoting the education of the girl child is very important, improving the socioeconomic conditions. All these things can lead to the complete immunization. Coming to the one most important aspect as far as child immunization is concerned, the information for the vaccination for the mothers comes from the pediatrician. So almost 77% of mothers say they get the information from the pediatrician. So we play a very important role as far as talking to the parents, convincing them is concerned. And what is the biggest impact of the decision as far as vaccination is concerned? Again, it is the doctor's advice which goes very far. It is our responsibility of the private practitioners to educate the mothers to take the vaccinations. So last slide, I think, Nistal, but can take our,
Yeah.
anybody can take. How to
Before
improve the national
before I take up, as in the beginning first lecture, Dr. Amdekar sir has said, and Dr. Pramod Jog has said during many his conferences, that we are a big pediatrician. B is every child's visit, breastfeeding and nutrition must be discussed. Second, I is immunization. Also, every child visit, even sick child visit, we must discuss about that child's vaccination and the siblings vaccination and parents and grandparents vaccination. So adult vaccination also come. And last one is growth and development. Dr. Samir Dalwai last lecture yesterday he told. So if we start developing and practicing this big thing, then definitely this vaccination coverage will improve at private setup. Financially also will be helpful, and overall health of the nation will improve. So to curtail this, in 2018 we started one program called Impact, Immunization Practices to Achieve Coverage Target, and that was an eye-opening things was done in the 2016-17 by UNICEF, the Surat PSM department, the Baroda PSM department. There were lacunae in private practicing pediatricians about missed opportunity of vaccines. If we can reduce mixed opportunity of vaccination as much as possible, the vaccine coverage can go up to 20% in our setup as well as across the country. So this is very, very important. Now there will be a provider, the parent related and the logistic related missed opportunities. If we can create tracking of each and every patient every time, the next appointment reminders been given, the SMS are sent. Now patients are waiting for that, and I have experienced if there is some miscommunication and there is no phone call or a message given to them, they miss the vaccine appointment. So if that has been done, then tracking of those children, logistic inventory management of the hospital is very, very important, because child come and we don't have that vaccine available at our fridge, we can definitely cannot give. Second, we must know there are almost zero or less complete contraindication of any vaccination. So minor illnesses, we must give them vaccines. Another thing is we stop by giving only 2 injections at one appointment. It can be given up to 9 injections, 9 vaccines at single visit. If we start doing that, then this kind of missed opportunities can be minimized, and we can definitely increase the vaccine coverage. Gradually, pediatricians are one who will be going for adult immunization. So we must start talking to the parent about adult immunization also. The influenza, pneumococcal, the shingles vaccines which are available, the typhoid fever vaccines also which is there. We must start talking to all these things. So the complete umbrella cover can happen and the missed opportunity can be reduced, and we can definitely add this into it. I request Dr. Samir Shah to add something on Impact 2.0 and 3.0. So what is there and what is future?
We would request to all the panelists to keep their answers little shorter because we are running out of time. Thank you.
So definitely, in short, because this is a total 3-year project what we have done from 2021, and Mr. Bhatt rightly say we require education, education, and education only. But this education include the education to parents, education to practitioners, and education to the society and government. And these three education level, what we did in the Impact 2.0, and for that we require the spreading started with the education means awareness in the pediatricians, how they can improve their coverage. Second is we can also prepare our own impact certified center. Out of that 51 facility, we had already certified 48 in thing with a proper schedule criteria of the prepared with a proper Google form with a self-assessment followed by the 2 mentoring visit and final assessment visit followed by a certification of having a 16 of the must criteria, 14 of the desirable criteria, and 11 of that survey criteria questionnaires. So this is the very important targeted schedule and impact 2.0 what we absolutely created. And last but not least, that is the preparing a standardized IEC material. That is the also we having an excellent target that we had prepared. So these are the 3 things what we require, that education, education, and education, and that will be fulfilled by the Impact 2.0. We are definitely hopeful for the Impact 3.0 and the more to increase this coverage target to the more and more pediatrics practice, that is what the private practitioner, and 10% of that overall over and above the government, they are giving the vaccination. Thank you.
Thank you very much, all the panelists. I think we have exceeded the time.
Just a minute.
discussion. Don't
First,
miss any
I am promising that I won't take much time. I will be as short as possible. But let me introduce myself first. I am Dr. Hitesh and I am representing the Community Medicine Department, Medical College. So we are from the public side, and we are happy and we are feeling proud to become the partner of this particular conference, and this is the beginning of the partnership. So we are happy, proud to become the partner with the IAP as well as the UNICEF. A word about the department. The department is working for the education is one of the agenda of the department. Along with that, we are working in collaboration with the development partners like UNICEF, ICMR, and along with the other agencies also. And for the IAP and for the UNICEF, any support is required for our expertise, that it can be in the public health, that can be in the research guidance. We are just a call away, or otherwise also we are in the geographical proximity. Anytime we are just a call away. Now let me summarize whatever we discussed. So number one is we did the situational analysis, and the take home message is still we are having the clusters where poor immunization coverage is there and chain of transmission is going on. Second thing is that how to tackle, what are the reasons of that particular cluster. Let me tell you that all clusters are having the distinct reasons, and they are all different reasons where of the poor immunization coverage. Urban we talked, but we didn't talk about the tribal sitting in Valsad district, nearby to the Dang district. Tribal is also our one of the priority. Along with that, third thing is that what I envisage from this particular panel discussion is that documented strategy to improve the immunization coverage with exact specific role of each and every stakeholder, and ultimately I will summarize the points. I will try to explicit the role of each and every stakeholder after this panel discussion, and we can try that particular strategy in Valsad district as a pilot also. But one of the things which I learned today, or Dr. Sunil Nayak is my good friend, so I was aware about the impact. But impact is one of the strategy which we should implement here also. But Valsad can start with the things, and it can be that this conference can be the point of beginning of the public-private partnership with the medical college, IAP, and UNICEF. Thank you for giving us the opportunity to become the partner of this conference. Thanks.
We would like to thank to Dr. Surendranath, who presented this topic beautifully, and all the panelists and chairpersons who took active participation in the conversation. Thank you so much, everybody, for being on stage. And with this, let's give them huge round of applause. And